Welcome, everybody. It's a pleasure to see you today and to meet you today, even if remotely. My name is Francesco Gavazzi, and I am a child neurologist that is currently collaborating with Dr. Edeng and Dr. Van der Ver of around many aspects of AGS. And the talk that I'm going to present to you today is going to be around clinical outcome assessments in AGS specifically. On the next slide, you can see that I have nothing to disclose about myself. In the next slide, you can see the outline of today's talk, which is going to be around the definition of what is an outcome measure or an outcome assessment, and how we can use the existing outcomes or in general outcomes and validate their use for applying them into rare disorders, specific rare disorders. What is an outcome measure? What is an outcome assessment? An outcome assessment is a measure that describes or reflects how a patient feels, function, or survive in general in the daily life. And it's very important to determine which tools are the best to describe the standard abilities of a population. But at the same time, it's also very important to determine which ones are the best to evaluate changes within a clinical trial, for example, or a rehabilitation treatment, for example. There are different types of outcome measures, outcome assessments that are subdivided based on what we are capturing and how we are administering that. So we have some assessments that are based on the execution from a child, from a person of a specific task in front of a provider that evaluates the quality of the execution of the task and also the time that is required to complete that task. There is also the possibility for the provider to observe behaviors or symptoms or situations in general during a visit and score a specific scale or complete a specific checklist based on the clinic of the patient. But also there is the possibility to have a provider that just scores reported information from patient's condition. Or the last one is what is defined as patient-reported outcome. So basically, what patients, or if the patient is too young or is for any situation unable to provide an answer on some specific questions, a caregiver that basically can answer specific questionnaires or complete specific checklist, and then those are used to basically evaluate what is the function of the patient from the patient or the caregiver perspective. On the next slide, you can see that measuring functional abilities, functional levels within a population is an extremely complicated process, because basically there are three domains that are very relevant to evaluate how a person functions in the general daily life. There are cognitive abilities that are including expressive language, receptive language, or working memory. So basically the ability to speak, the ability to understand, and the ability to retain informations that are provided and use them to complete other tasks. For example, like one of the most common ways of evaluating working memory in the general population is telling the person a series of numbers and see if the person is able to recall them and how many of them they can recall over time. Another important domain to evaluate the functional abilities of a person is the motor abilities. So basically, we are trying to determine how much a person is mobile or is able to change posturing, and that is what is defined as gross motor abilities, or how much the person is able to manipulate, how well is a person is able to manipulate, and those are the fine motor skills. And then we have adaptive behavior abilities, which are basically the abilities that a person has to adapt themselves to the request of the environment and respond to the requests of the environment. And this is a very important field because it evolves very much with the person over time. Because the request that, for example, a 2 years old can have to face from the environment are very much different from the ones that a 25 years old might face over time. And then there is a fourth domain that is, in some extent, including the previous three, which is quality of life, which is basically how a person is able to feel happy and to feel content with the standard of living that they're able to achieve during their daily life. One element that complicates even more the picture is that all these assessments, all these domains are extremely intertwined one to the other. So it's very difficult to separate one specific function and examine one specific function only because of this very close association. So it's very important to always keep in mind that we are never measuring one single ability of a person at a time. We're always measuring multiple ones, or almost always. Another element to take in consideration when we consider outcome measures is that some of them are quantitative and some others are qualitative. And they're both very important, but different one to the other. A quantitative outcome measure, it's a measure that gives me a final result of a number that can be compared with other numbers, and I can compare basically the performance of one person with the performance of another person at any time. And so basically you can see the usefulness of this. And the distribution of the abilities of a person is usually as a ghost curve, which is basically the image that you see on the right of this slide. So basically you can see how the vast majority of the population is included in the in the bigger area of the curve, but when I go outside of what is considered the traditional functional ability of a person, or I go outside of what is considered typical or average in a population, the assessment tend to be less precise. The two tails, the two extreme tails between the -2 standard deviation that Greek letter, the sigma letter, and what is above the two standard deviations is not very well captured by traditional testing that is defined by, that is validated on a general population. Why that? Because a general population tend to have a predictable functional ability, while if I consider a population that has a condition, a genetic condition that in some extent can modify the abilities to function from a cognitive perspective or a motor perspective, this assessment might be less effective in describing the same population. On the next slide, you can see that I'm presenting basically what is a qualitative measure. So it's basically a measure that doesn't provide me with a number, but that specifically is focused on identifying what is important to individuals and family, what is relevant for them, in order to avoid measuring something that is not relevant for a population. And this often involves the recording of information, collecting information around what are the challenges that the patient or the person in general faces on their daily life, and what are possible barriers or what are possible feasible improvements that might actually increase the quality of life. And quantitative measures and qualitative measures should always be paired one to the other to basically find what is relevant from a clinical perspective and what is relevant from a family perspective. Now I'm going very briefly to present you how we select outcome measures in rare disorders. In the next slide, you see that even in rare disorders, the categories that are used to evaluate functional abilities are the same as in the general population. We're evaluating motor abilities, cognitive abilities, adaptive behavior abilities, and quality of life. But we need to consider that because this population is a specific population, we need to avoid what is called a floor effect and the ceiling effect. So a floor effect is when I choose a test that is too challenging for the population that I want to describe, and so everybody performed poorly. What is the problem in that? That if I have a test in which everybody performs poorly, I am unlikely to see a possible change in function in the sense of a decline, but also small improvements are missed in that way. On the other way, if I choose a measure that is too easy and a test that is very good at evaluating, in a test that in which basically everybody is scoring the maximum, it's an assessment that is quite good to evaluate a decline of function, but it's very bad to evaluate possible improvements. And so you see that I want to stay in that mid spot, that soft area in which the test is not too easy but not too difficult, because in that way we can evaluate change. Another element that we need to take in consideration when selecting measures is asking ourselves questions beforehand. What do I want to measure? Why am I using these outcome measures? Is this test that I'm going to do a test that is reliable and reproducible, or is it just a one shot? Because that is something that I don't want. What do I want to measure? Do I want to measure quality of life? Do I want to measure motor abilities? Do I want to measure independency? Do I want to measure function? And which outcome measures are the most valid and the more appropriate for evaluating those specific areas? So these are all questions that need to be answered beforehand. On the next slide, you see that I am very quickly presenting about how do we validate outcome measures. It's a very complicated approach, but basically we need to have multi-steps that allows us to determine what is the sensitivity of the assessment to dynamic change and avoiding the floor and ceiling effect that I've described before. And if an outcome measure does not fulfill these requirements, it's still possible to modify them and to make them disease specific by either taking out some pieces or only including some other items. In the next slide, I'm just very briefly summarizing all the elements that I presented in this presentation, but basically final elements like the selection of outcome measures. It's a complex topic, but it's a very important one because basically it allows us to evaluate how a population performs over time, but also how I can define improvements or declines that are in one situation associated with the natural course of the disease, but also on possible specific treatments. We always need to take in consideration that we need to have an association of quantitative and qualitative measures because they are both relevant in their own way. And these are necessary measures to determine clinical trial efficacy. And we can always be a little bit creative in modifying what we have available at the moment and make it more specific for a disease. And with that, I'd like to thank Dr. Van der Ver and everybody, Dr. Edeng, and everybody else that is collaborating in this communal effort of trying to define which are the best ways to evaluate these children and the best and more fair way to evaluate them in with a methodology and with an approach that is going to be useful for describing how they're doing, but also to evaluate how they can improve under a specific treatment. And with that, I'd like to thank you so much for your attention and have a great rest of your day.